So without further ado, I'm going to stop sharing my screen and I'm going to turn it over to Dr. Kwolek, who is the lead for the Women's Health and Sex and Gender-Based Medicine program at Massachusetts General Hospital. And we are very happy to have her here with us this morning.
Good morning. So glad that you're all here. Let me just get my slides ready for you. I'm a menopause specialist, and I also do consultations at the Brigham and Women's Menopause Clinic. So be glad to see anybody who'd like to come visit us. So this morning, what I'm going to talk about just very briefly is what you all should do about menopause if you're at risk for breast cancer. And I realize the audience is probably very diverse. So unfortunately, it's very difficult to address everyone's concerns. There are those who have concern about breast cancer, but actually you're at an average risk. There are others who have a slight increased risk, maybe just as was pointed out, alcohol use, for example, it confers just a small risk. And sometimes for certain women, using hormones is just in that risk category. It's actually not a huge risk. Then there are others who are at higher risk. And of course, women who've had breast cancer. So it's very diverse. So I'm just going to talk about menopausal symptoms, some things about estrogen therapy and some controversies, a few patient scenarios, and how some specific menopausal issues can be treated. So menopause, as you probably know, is the loss of ovarian function. Average age naturally is age 51 to 52. For most women, you would cease having your menses, and you would have low estrogen levels after that. There's causes such as just natural menopause, but then women who have had breast cancer or breast cancer treatments may have had a surgical menopause, or they may have stopped having menstruation or have early menopause due to their treatments. So the common symptoms are known to everyone. The most famous is hot flashes, which can also be night sweats. And this is something that can start even in the perimenopausal period. For many women, it can start in your late 30s and 40s. This is accompanied often with trouble sleeping, mood issues, and depression. During menopause, women lose 10% of their bone mass if it's not treated. And then long-term, there's an increased cardiovascular risk, genitourinary symptoms such as painful sex and dry vaginal tissues, and weight gain. So how do we treat this? Estrogen does work the best, but it's not for everyone. So there are a lot of alternatives and treatments for hot flashes that have been marketed and promoted on the internet. But what's important is that you work with your physician to see if estrogens are supposed to be avoided for you, then be cautious about the supplements that are online. Make sure that those will also be safe for you. And we'll talk about estrogen in a minute, but the non-estrogen treatments we use are usually targeted at specific symptoms. So the most common symptoms, as we said, for the short term at least, are the hot flashes and the mood swings, sleep issues. So the SSRIs and SNRIs, such as Zoloft, sertraline is the proper name for that, the generic name, and those types of Effexor or venlafaxine, those types of medicines, they can be very good for both the mood symptoms and also they reduce hot flashes by about 50%, but they don't address the bone and the other issues. But we have other medicines for that. So if you cannot take estrogen, this can be a really good first step. The other thing that we give is gabapentin, which you've probably heard of. You may have heard bad things about it. It's used for chronic pain, but in small doses, such as 100 to 600 at night only, it can be very effective, especially if you're being woken up with night sweats. And it also has a nice calming effect, helps you sleep better, and it has a little bit of anti-anxiety effect. There's a new medication, fezolinetant, that has been widely marketed. You probably have seen the ads. It's also called Veoza. This is something that is novel. It's only been on the market for just about a year and a half, and that reduces hot flashes directly in the brain. We have new data that it probably also helps with sleep, and there are newer iterations of this medicine that will be coming out. So this is something to keep an eye on. But this in particular can be very helpful for women who can't take hormones for other reasons or have had breast cancer. And we use this quite a bit in that population. And then I don't want to rush by the fact that vaginal treatments are very important because we don't want any of our patients to have painful sex or pain in the genital area. This is often a neglected area. So for a lot of women, actually most women, unless you're actively being treated with an aromatase inhibitor or have been told by your physician that you can have zero estrogens. Vaginal estrogen moisturizers and lubricants are very recommended, and the topical products are not absorbed into your bloodstream to any large extent and are very, very safe. So in terms of breast cancer risk, again, it's just such a broad topic depending on your individual risk, and that's why this B-PrEP program is so important. So if you have a hormone, and there's two types of hormone therapy. There's the systemic, which goes throughout your whole body, and then there's the topical that I just referred to. So the systemic therapy is contraindicated if you have a hormone-sensitive cancer, and so then that's great. And I already mentioned the other things we can use, and there's much more to help you with menopause. There should be clear communication between yourself and your doctor, and usually it's going to be a team. If you're at high risk of breast cancer, there's going to be whoever's seeing you for medical oncology. Your PCP may or may not be familiar with menopause and some of these treatments, so we're going to want to set up a team where everyone's talking. You're going to hear more about breast cancer reducing medications. And one of them that is exciting and is being studied here is called Duave, which is actually a combination of estrogens and a SERM or a anti-estrogen, which is the type of medicine used to prevent breast cancer. So you'll hear more about that. We don't have as much data as we need, but we're finding out more. And then it's important, as I said, the whole team is involved, and topical hormones may well be permitted for you. So patient scenario, the $1 million question is, do estrogens cause breast cancer, or do they just cause existing breast cancer to grow? And this is something that, we don't have time to get into this. There's different opinions based on years and years and years of research, and oncologists even disagree on this. But let's just say that either way, if you're not at high risk, we do not think that you should be afraid of estrogens if they are indicated for other reasons, and the risk that is maybe attributable to estrogen is actually very low for most women. So here's just an example of your scenario, and again, this needs to be individualized. If you're a 52-year-old woman, no family history, no history of breast biopsy, no chest radiation, you would be considered average risk most likely, and 100% you can take estrogen therapy if you would like to, and you're having menopausal symptoms. Similarly, a woman who her only risk factor is that her mother had breast cancer age 60, she could probably take hormones without worrying about it either. She has a slightly increased risk, but we would not consider that prohibitive. For women who are at higher risk, this is just where you need a more robust discussion with your physician. And again, your primary may or may not be familiar with this, so please take advantage of the B-PrEP team and the menopause consultants. If you have a high-risk lesion, if you've had treated breast cancer in the past, those are women where you still perhaps could take estrogen therapy, but it would have to be a shared decision. We would have to talk it through. Interestingly, though, BRCA patients that have been treated with mastectomy and oophorectomy, we can give estrogen safely, and this has been recommended by the Menopause Society because so many of those tumors are ER negative and just for complicated reasons. And we do want you, if there's no contraindication, to take estrogens, by the way, up to age 51, 52, if you can, if you've had treatment for breast cancer or preventive treatments, and you've stopped menstruating. If you can take estrogen, we do recommend that to protect your bones and heart longer term. After age 51, the natural age of menopause, then we can have another discussion. And then if a woman has current breast cancer, clearly we're probably not going to give estrogens at all, perhaps topical, but that again is a complicated decision depending on your individual factors. So finally, these are the things that you're going to hear about more this morning. How lifestyle medicine helps with the risk of breast cancer. The night sweats I already referred to. And again, calling to your attention, the new one, fezolinetant, is something to keep your eye on. There's some complicated things here your doctor will want to look up. If you are going to take a selective serotonin reuptake inhibitor, for example, and you're on tamoxifen, there's some theoretical reasons to avoid certain of them more than others. So again, it's just something to discuss with your physician. If you're having trouble sleeping, this is super important. It's probably also important for breast cancer risk. And the only thing I wanted to point out here, there are many medications available as well as non-medical ways. But sleep apnea, I wanted to give a shout out, is actually much more common in women than most people realize. So if you're really having trouble, ask your doctor about seeing a sleep specialist or having a sleep study to make sure that's not an issue for you. Finally, the mood swings. A lot of women end up feeling like they're having uh, PMS every day is just one of the common things that we hear. And depression and anxiety are very common in women anyway, up to 30%. But with all the hormone changes that go on in the perimenopause, the menopausal time, and then certainly with lack of sleep, this can be a big issue. So I just want to encourage you, if you have these symptoms, don't ignore them. And some of the SSRIs and SNRIs I already mentioned are good both for hot flashes and for mood. And even if you can take hormones, these also still work well together. So these are things that I hope that you will discuss with your physician just to get it treated by one way or another for your own sake and also for the people in your life who count on you. Bone loss, I just want to say a few more words. This is really important. It used to be that we gave hormone therapy and also raloxifene, which and tamoxifen. All three of those medications are very beneficial for your bones. And it used to be that we would treat women to prevent osteoporosis pretty aggressively and routinely with hormone therapy to prevent bone loss because all of us lose bone over time as we get older, but right around the menopausal transition, just those 2 or 3 years, you'll lose 10% of your bone mass. So this is something to consider. Consider taking either estrogen or, again, tamoxifen is good if you're going to take that for breast cancer prevention. But either way, we do want to consider our bones. The trend among endocrinologists right now is to wait until you actually have osteoporosis in your 60s and 70s before they treat it usually with bisphosphonates and other medications. But just consider your bones when you're younger, and the weight bearing exercise and the vitamin D and calcium are very important for that. Weight gain is one thing we hear a lot about, and unfortunately, hormones are not a magic pill for this. There are a lot of reasons people gain weight. In menopause, I tell my patients it's sort of like a reverse puberty. Along with age, men gain weight also, but with the hormone changes that happen, it's very common to go through those menopausal changes and end up with more abdominal fat than you were used to. Some of this is due to the hormones, and some of it is due to just sedentary and other factors that creep into our lives as we get older. And as we just heard, this increases your risk of breast cancer somewhat. So again, no fat shaming, or you should feel good about yourself and love yourself and all that. So please don't get the wrong message. But this is something that's very important to pay attention to. And if you are a candidate for hormones, it will help. It also can help prevent diabetes and can prolong the onset of diabetes if you have prediabetes. So just something to put into your equation. Finally, cardiac risk. This is something that we don't have a talk on today, I don't think, and we can talk more about this in other settings. But this is very important. And so as you enter into menopause, whether or not you can take estrogen, consider actually with your doctor assessing your cardiac risk, see if you're at increased risk, and if you have diabetes, smoking, other risk factors, make sure you're paying attention to those and talk to your doctor about, whether you would be a candidate or whether you would benefit from a statin therapy or other therapy. The genitourinary symptoms, as I already mentioned, are super important. And in addition to topical estrogen, which is safe for almost all women, or I say almost all, but either way, please, moisturizers for you, lubricants for your partner are super important. And then if you've got a lot of symptoms because you're on treatment, especially with an aromatase inhibitor, then this can be very problematic. In those cases, we would probably not give you estrogen because we're trying to bring your estrogen level down to almost zero with those medications, but there's a lot more that can be done. So please do not suffer, and be sure to talk to your doctor about this. And on the heels of that is sexual health. I want to put a shout out for sex therapists you can access online, and for pelvic floor physical therapy, especially if you have had any treatments that involve your genital area. So in conclusion, please make sure that you have the correct info and that you and your providers are communicating and that your providers are communicating with each other. There are some doctors who will just tell their patients, I don't believe in hormones, they're going to cause breast cancer. And that's not really the right answer. That's based on 20-year-old data, and you deserve a more robust discussion than that. So keep searching till you find someone who can help answer your questions. Again, lifestyle and alternative medicines can be the front line. Interestingly, though, they're very good for you in general, but they're not that great for menopausal symptoms per se. So that's just something that's a little bit unfortunate, but that's the truth. Estrogen therapy is very safe for most women, although the use is controversial. And there are many other medication options available if you do not want to take estrogens or cannot take estrogens. And lastly, topical estrogen, as I mentioned, is safe for most women. So that was a super quick overview, but I want to save time for questions.
Wonderful. Thank you so much. So we do have a one question in the chat, and please, everyone, feel free if you have any additional questions. So Kay Thomas would like to know more about the pros and cons of Duave.
Okay. Well, again, it sort of depends on your situation, but the pros of Duave, however you pronounce it, is that it contains both estrogens and a SERM. So the presumption that we're trying to prove, and so far preliminary data shows, is that you'll get the estrogen, which will help with the menopausal symptoms, and it'll give you a positive effect, hopefully, mostly on hot flashes, which is just the most immediate concern, and also in the genital tissues, the vaginal symptoms, but that also potentially long term it could have other positive effects that estrogen has, and that's paired with the SERM, which is similar to tamoxifen or raloxifene, not the exact same profile, but very similar, which would block estrogen receptors in your breast so that hopefully, would have a similar effect. The other SERMs of reducing your breast cancer risk. You're going to hear more about this later this morning, but so that's really in a nutshell how it works. We're very excited about it in the menopause clinic, women who we're waiting for more data, but in the meantime, women who do have a increase to higher risk, but are still able, it's not absolutely contraindicated that they can take estrogen. We are offering this to a lot of them. We're getting back good preliminary feedback from our patients that it takes care of their symptoms. And whether hopefully in reality, but also just psychologically, we kind of all feel better about it, adding in the estrogen, the partial agonist. So
Great.
I would say talk to your doctor about it. Yeah.
Yes, and you'll hear later this morning, we are running a clinical trial testing Duave, and so you hear more about that later today. Another question about arthritic pain during perimenopause and the impact of hormone replacement therapy for those that are at high risk.
Absolutely. So I always tell my patients, there are many symptoms during menopause and perimenopause. And if I give you the hormone therapy, it's going to fix the things that are actually due to the hormones. And if your symptom's not due to hormones, it's not going to get better. And then there's some things that partially get better. So arthritic pain is a huge example of that. So the most common arthritic pain that's actually caused by your changing hormone levels is to have, pain and stiffness in your hands. And some women have it more diffusely in their joints. If you have a shoulder injury from before, obviously that's different. And that can actually be really helped with estrogen. So that's not the main reason we give it. It's more of a benefit. Some women come to me and it's always like a toss up because the main indications for estrogen therapy are hot flashes and to prevent bone loss and the sleep issues. So if you only have the joint pains and nothing else, that's a little bit of a stretch, but still the proof's in the pudding. You can try the estrogen, see if it helps. And we've had a lot of women with like a really funky pain, like different pains all over their body that can get better with the estrogen, including just, one inflamed shoulder. So it's probably worth a try if you don't have any contraindications.
And then a couple questions about the length of time that it's safe to use hormone replacement therapy. And again, is there an age past which estrogen therapy does not help?
So this is really cool the way I think of it is if you're under 50 and there's no contraindication, you should take estrogen. if you don't have your own natural estrogen. 50 to 59, unless there's a contraindication, we believe it's very safe to initiate hormone therapy and to take it. And at most, you know, we're not saying everyone should take it, but most women feel a lot better right away. So, and we consider that very, very safe. We think that's the most likely that not only you can have benefit now, but you may have benefit up the road. If you're age 60 and above, it's not contraindicated to start hormones, but we're a little more careful. And so, 59 and under is the sweet spot. If you're 50, if you're 16 above, if you've already been on it and you're doing well, we don't have to stop. In fact, the American College of OBGYN and the Menopause Society together both have lifted any recommendations that it be stopped at a particular age. I mean, if you're doing really well, 69, 70 years old, you could continue safely. But we reassess it every year in terms of your risk and what other things are available for your symptoms. So that's that. So you don't have to stop. In terms of initiating, though, it's going to be higher risk for you the longer you've been in menopause. So in general, if you're more than 10 years past menopause and your body's had no estrogen at all, then doesn't mean you can't start, but that's where we're going to be a lot more careful and have a discussion about it. And if you really want to start because you're having really bad hot flashes or something, we might start you a super baby dose and work up, or treat you with more kid gloves in that sense.
Okay. A lot of positive feedback here. How about, I probably won't say this one correctly, the newer drug, Veoza, Veoza, how do you say that one?
Oh, Veoza, yeah.
Veoza. Given that it's relatively new, what do you feel about the data on women who are at increased risk for breast cancer using that drug?
So unfortunately, you're right. We don't have as much data as we need to have. We don't have any reason to believe that it would increase risk of breast cancer at all. But we don't know. So that's a good question. And this is a lot longer discussion, but there's tons of medicines that haven't been studied as well as estrogen, and the small increased risk you get from estrogen, we don't know. With other medicines, we haven't looked. So Veoza has not been studied on the same scale as estrogen. However, just theoretically and the biological plausibility, it works on, they're called candy neurons and kisspeptins in the brain, which are really cute names. And so we don't really have any biological reasons to think it would increase your risk of breast cancer. So that, and again, it's new, yes. So I don't reach for it right away if women can take estrogen or something else first, but we're getting more and more experience with it. There's more and more studies. I know my colleagues over at the Menopause Center, Kara Iyer and others have been prescribing it more. And I do prescribe it, yes. And so we don't know, but that's the best thing. If you can't take anything else, some women have said, I've tried this, I've tried that, nothing else works. Try it. We do have to check liver function tests frequently and things like that, but it can give relief. And I'm sorry to say, though, it's about 60% relief.
Okay, wonderful. So it sounds certainly like the messaging is changing, has been changing over the last several years, and it's good for our listeners, our patients, to know that there are specialized clinics now to be able to help with some of these discussions. As you've mentioned, it's hard for the primary care physicians and the OBGYN. Sometimes it's hard to keep up with all of the new options and the changes and the sort of historical message to stay away from all of it. That seems to be changing now. So good for our patients to have those resources and those options. So thank you very much.